Hi, everybody. Welcome to the all-virtual 2020 Los Angeles Net Patient Education Conference presented by LACNETS. I'm Lindsey, the Director of Communications for LACNETS, and this is...
I'm Lisa Yen. I'm the Program Director for LACNETS.
Before we get started, we have a list of people to thank for making today possible. First, we'd like to thank Rich at TVP Live. He's the tech genius behind all of this. We'd also love to extend a special thank you to all the speakers who participated today, as well as the patients who will be sharing their net journey stories with us later. As far as sponsors go, we'd love to thank our presenting sponsors, Ipsen Pharmaceuticals, as well as Sun Pharma. Other sponsors we'd like to thank are also Advanced Accelerator Applications, AAA, Lexicon. Before I forget, I want to mention that there's an opportunity to speak with some of the pharma companies today. Those participating in virtual exhibit booths, Lexicon and AAA. So if you have any questions for these companies, feel free to join in on their virtual exhibit booth. The details are on this webpage. If you scroll down a little bit, you have the link to click to join the room and ask your questions.
Thank you, Lindsey. I want to tell you a little bit about the history of LACNETS. LACNETS was founded a little over 8 years ago by Giovanna Joyce and Basie as a Los Angeles-based nonprofit dedicated to expanding awareness and providing education, support, and advocacy for those whose lives have been touched by neuroendocrine cancer. This past year has been an especially challenging one for all of us as we grieve the loss of our dear friend. Giovanna wanted us to remember that she lived richly and fully for 14 years with neuroendocrine cancer. And while she was an accomplished pianist and composer, she felt that her greatest legacy was founding and building LACNETS. Giovanna was especially proud of Net Vitals, a communication tool that she and I developed along with Dr. Dan Lee from City of Hope to improve the communication between patients and providers. Giovanna's hope was to help as many people as possible learn to thrive while living with neuroendocrine cancer. And we, the LACNETS team, are committed to carrying on her torch. Know that LACNETS is in fact led by a team. While you often see Lindsey and I leading the meetings and programs, we are led by our interim administrator and board member, Kavya Velagapudi, and board member, Donna Gavin, also the sister of LACNETS founder and executive director emeritus, Giovanna Joyce and Basie. In addition, we are blessed to have the counsel of our advisory board. LACNETS is not just a team. We are also a net community, a collaborative community of net experts, those living with neuroendocrine cancer, meaning patients, and friends and family supporting net patients. We collaborate with local and national net centers and organizations, and we aim to build and strengthen connections among those in the net community, knowing that when we come together and link arms, we are stronger together. We understand that living with neuroendocrine cancer can be really hard, and we acknowledge that this may in fact be even more challenging during these unprecedented times through living through a pandemic. Many people struggle with increasing uncertainty and feelings of powerlessness. So, we hope that today's conference will be empowering. Today is an opportunity to learn from net experts and patients across the country and hear from stories from the net patients and their families. In fact, today, you will hear a lot of information. The amount of information might feel overwhelming at times, so rest assured that this is being recorded and can be watched again on our LACNETS website and YouTube channel. Our biggest hope that you will come away today feeling encouraged, that you will know that you are not alone. There are many patients, caregivers, and advocates who are living through this too. We get what you're going through. Also, there are many experts and advocates fighting on your behalf. Today, you will hear from some of these net patients and experts who are fighting with and for you. At 12 noon today, Pacific time, we will have one live question and answer time with our net physician experts. Submit your questions at Slido, www.slido.com, and enter the event code LACNETS. So I'd like to introduce our first guest today, Cindy Lovelace, the co-founder and executive director of the Healing Net Foundation. Cindy is a NET cancer patient with a powerful story of her own as a survivor of 2 cancers and someone who models how to advocate for herself and others. One of the most common pieces of advice that newly diagnosed NET patients receive is to find a NET expert. So we've invited Cindy Lovelace to open the conference by sharing her insights about what finding a NET expert means and how to go about doing this. Let's welcome Cindy Lovelace.
Hi, I'm Cindy Lovelace. I am the co-founder and executive director of the Healing Net Foundation. And I'm going to be talking to you today about finding a NET expert. That's a big question. And during this presentation, I will be sharing some of my own story because I am a NET patient as well. I was diagnosed with a pancreatic neuroendocrine tumor back in 2011. So I will share some of that, but I'll also share some things that I've picked up from talking to patients and doctors all across the country. So finding a NET expert. Let's get started. If you walk into a doctor's office and it looks like this, you might be in exactly the right place, finding a NET expert. But you got to figure that's probably not going to happen right off. You're going to have to put a little bit of research and a little bit of time into figuring out how to find a NET expert. You may have been newly diagnosed and you're really confused because a lot of the information doesn't seem like it pertains to you or it's overwhelming. I'm a zebra? Wait a minute, I thought I was a donkey or a horse. Oh, and I've been diagnosed with cancer, so I go see an oncologist, right? Well, unfortunately, it may not be that simple. And people are telling me that I need to see a NET expert. What about those of you who have spent years in and out of various doctors' offices and you've been frustrated at getting some of the questions answered, or you're getting conflicting information? Maybe you've seen oncologists, even surgeons and GI doctors. And these healthcare providers told you that they did know about neuroendocrine cancer. So who is a NET expert? You may be very frustrated and even angry at this point. So look, we've been diagnosed with a very, very complicated disease. And it's often misunderstood in the medical community as a whole. You're likely to have this condition for life. So that brings us to this big question. When seeking someone who is going to be directing your care for the rest of your life, how selective do you want this process to be? So you might consider a Highlander warrior or a combat nurse. That would be really great to have in battle, but that may not be someone you want directing your medical care. And you probably don't want this guy who's chasing windmills. A little bit of humor here, but it's to make a point. You want to invest some time in finding a NET expert. So a lot of questions, right? Let's dig into the questions. The first thing you have to do is educate yourself. And before you put a doctor to the test, you'll want to do your own homework. You want to learn as much about the disease as you can. But I'll caution you, don't Google neuroendocrine. Here's some vetted websites that are really great at giving you good, solid information about neuroendocrine cancer. And of course, the one at the top here is one you're probably very familiar with, being at this conference, and that's LACNETS. Then there's NorCal CarciNet, which is in Northern California. There's the Carcinoid Cancer Foundation. It's been around a long time. There's the NET Cancer Awareness Network. There is also NET Research Foundation, or NETREF. And then, okay, it's a personal favorite, the Healing Net Foundation, thehealingnet.org. These are places where you can find some really good information. So I'm going to focus on one of our publications from Healing Net, and that is our NET Primer for Healthcare Professionals. This is our second edition, and even though it's written by NET experts for providers in their language, it's actually pretty readable by patients and caregivers. You can get a free copy by going to thehealingnet.org and requesting one to be mailed to you, or you can download one right there on the website. The feedback that we have received from the patients is that they've walked us in to their doctor or nurse to teach them more about neuroendocrine cancer, because we want them to understand that it is different, that it is a zebra and not like other more common cancers. So this is an important question. Who is going to care about your quality and quantity of life more than you? So do your homework so you can be prepared to find a NET expert. The next thing you want to consider is your insurance, unless you're self-pay. So if you're Medicare or Medicaid, it's important to know what is and is not covered. If you have private insurance, you want to get familiar with your policy so that you can make sure that you know what procedures are covered, and make sure to ask when you go to a new provider to make sure that everything, including all the providers involved in that procedure, are covered, and also what medications are covered. And here's a side note. I mentioned that the websites have a lot of great information. There's also information on there about financial assistance. And so you can go there and find out things that are covered if your insurance is not covering it. A lot of the manufacturers of drugs like your shots, your monthly shots, can offer you financial assistance. And during COVID-19, even some Medicare patients can be covered. So again, if you go to thehealingnet.org and click on patient resources, you can find out more information about that. So where do you look for a doctor? So here's where I draw the line at Google again. For sure, there are lists for doctors on the internet. This looks like a good site. It's US News and World Report's top doctors. So let's plug in Neuroendocrine in Los Angeles, California. And let's see what we come up with. Oops, page not found. Looks like something really went wrong, all right. No neuroendocrine experts there. So let's go back to one of those vetted websites that I shared with you earlier. They have searchable lists for NET doctors. So I put in a search for California, and as you can see, several NET specialists have popped up. I just bet you recognize a few of them. So let's try my hometown state of Kentucky. Well, there you go. At least there's one. Now, let's try where I live now in the state of Tennessee. Nothing. Well, I happen to know that has changed, and there are some NET experts in Tennessee now, but of course lists are always changing. And this is not a criticism of this list. This is actually a very valuable tool to start, but there's more. But what a search on a great website has shown, there's still a big problem of access. Depending on what state you live in, may create an opportunity or an obstacle to finding a NET expert. Let's dig deeper into another big challenge. In the US, there's no established criteria for what defines a NET expert. The Healing Net Foundation undertook a big project a year or so ago, and we asked some cancer centers that are known to have at least one NET expert if they could see how they stacked up with criteria from European centers of excellence. Now, you have to remember that healthcare systems there are very different. And so what works there is not going to translate the same into the US. But if you look, you can see that there's some acceptable number of answers here. Some have seen a lot of NET patients in a year. They have experts in various disciplines, including NET nurses. And they conducted regular tumor board meetings. But they also have some areas to work on, like administrative bureaucracy. Agreement on treatment paths, interaction between the disciplines might be all over the place within the center, and there may be a lack of patient participation in clinical trials. Now, this survey is available on our website, but the centers are anonymous for now. This was a first step, and what we're hoping to do to see if the centers will next publicly self-report this information. Again, giving you an opportunity to choose what key measures are most important to you. So armed with the knowledge and vetted information to share, an understanding of your insurance, some potential list, and understanding some of the challenges, I go back to what kind of doctor are you looking for? If you're newly diagnosed with a tumor, you may be headed to a surgeon or interventional radiologist, or an oncologist if you have a high-grade tumor, Or if you need help with symptom management, an endocrinologist or a GI doc might be for you. And you might want to consider one of the newer treatments like Lutathera or PRRT, so you might be looking for a nuclear med doctor. Or you might need to choose a doctor, a local doctor, who is not a NET expert, but is open for consultation and collaboration. So that's where we come to some questions. The Healing Net Foundation has conducted some surveys over the years exploring the doctor-patient relationship. And one of the top concerns for patients was having a doctor that they had trust and confidence in. So when you're in front of your provider for the first time, here's some questions you might want to ask. How many NET patients do you see in a month? If the answer is 1 or 2, that might not be so great. 5 to 10 is better, 15 to 20, 25 to 30, even better. Do you have a multidisciplinary team of NET experts at your facility? And would my case be considered by a tumor board? This may be a very important question for you because of where you are in your journey. You may want to ask the provider, are you a member of NANETS, which is the North American Neuroendocrine Tumor Society? And you follow the NANETS or the NCCN guidelines, which are guidelines for all types of cancer, but they also have guidelines specifically for neuroendocrine. So you would want your doctor to either be familiar or be willing to seek out those resources for those guidelines. And then you might want to throw in a little NET terminology because I hope you've done your homework, but you've now become familiar with some of that terminology. So you could throw out there somatostatin analogs, PRRT, carcinoid crisis, and just kind of see where that goes. The other top attribute that our patients told us was really important to them was a provider willing to listen. Does he or she spend enough time on your initial visit to understand what you currently need? If they don't know the answer to your question, would they be willing to seek and consult with a NET expert? You have some list. If you are not in a state that has a NET expert, this could be an option for you. And is there a clear channel of communication within the provider's office? Really a bonus if there's an advanced provider to answer questions if the doctor is not available. This could be a physician's assistant or a nurse practitioner. Now I'm going to tell you a little bit about my own cancer journey. So I started out as a breast cancer survivor, and I was 6 years into that journey. And my oncologist, she was a rock star. She steered me through chemo and radiation, and I was cancer-free until that incidental NET tumor was found in 2011. And my oncologist didn't know about neuroendocrine or have any access to information, but she gave me a gift. She told me that. She also sent me to a great surgeon who successfully resected the tumor in the tail of my pancreas, but also told me to live my life cancer-free again. So now I'm a zebra, and I had to do my own homework. Okay, I admit I did Google. And whether it was plain luck or divine guidance, I found a doctor right across the street who had established a neuroendocrine center. Now, turns out my oncologist knew him. Their family socialized, but she did not know he was a neuroendocrine surgeon. And turns out he is exactly what I needed at that time. He had started a clinical trial for the gallium-68 dotatate scan, and that scan showed up 2 tumors in my liver that an MRI had shown to be clear. It completely changed my treatment path, and I ended up co-founding the Healing Net Foundation, but that's a whole nother story. Now my path has changed again. After a couple of surgeries on my liver, some small tumor growth in other areas made me consider a more systemic treatment. So I recently went through PRRT, and so my primary NET expert changed. Although my surgeon and my oncologist are still in the loop and involved in my care. So here's a bunch of NET experts at one of our Healing Net summits. And I go back to the question earlier. You might find a NET expert based on what you need right now, or you may need a multidisciplinary team to get together and discuss your case in a tumor board. Or you may not have access to a NET expert at all. So you could choose to travel, like I did, or you may put pretty heavy emphasis on that question we talked about. Are you willing to consult with a NET expert? So you've done your homework, you've educated yourself, you've sorted through insurance and list, and you've asked questions. Now you have to choose based on what's important to you. And always, always, you want the provider to get it. You got to think zebras. And I will tell you, it's absolutely fine to seek a second opinion. Would you do that for an expensive car repair? Would you have a home inspection before you bought the house? What is more important than your health? Nothing's more important. You want to choose someone who's going to be your quarterback, or if you prefer, a conductor. They either have the expertise or they're willing to consult with an expert, where you will have trust and confidence, good communication with them, and therefore a good partnership. I will tell you, don't settle. I'm a sailor, and there's a wise saying about the journey. When you're on a boat navigating unknown waters, the saying goes, you cannot direct the wind, but you can adjust your sails. And that's because you have one trusted voice on the boat, the person at the helm. They know the boat, they know the waters, and they know how to adjust those sails to get the optimal navigation or how to get you out of danger. So at the helm, do I want this guy, Captain Ron? Or maybe I want this guy. He's won 3 America's Cup championships. Whoever you choose, you want someone who's going to navigate you through one of the most important journeys of your life and all your life, with knowledge of your disease, with good support and references, by asking the hard questions and choosing what's acceptable and what's not for you, with good communication, trust, and confidence in your choice, then you know you have done the best job possible of finding a NET expert. Thank you. And I encourage you to email me. I'm Cindy Lovelace at thehealingnet.org if you have any questions about any of the presentation or anything else on this journey of neuroendocrine cancer. Thank you.
Thank you, Cindy, for your powerful presentation. We've now learned how to go about finding a NET expert through vetted websites like carcinoid.org and NET Research Foundation. We've learned specific questions we might ask to establish trust and build confidence. When someone is first diagnosed with neuroendocrine cancer, one of the first experts he or she might see is a surgeon. With NET, this is often a surgical oncologist, a surgeon who has special training in treating cancer. Our next speaker is one such NET expert. Dr. Alexandra Gangi is a surgical oncologist at Cedars-Sinai Medical Center who specializes in neuroendocrine cancer. We've been very fortunate to have her speak at LACNETS several times in the past and appreciate her insights. We especially appreciate Dr. Gangi's incredible kindness in accepting our last-minute invitation to join us today. Let's welcome Dr. Gangi.
Good morning. Thank you all so much for tuning in. Thank you to LACNETS for the opportunity to speak to you all today. I could tell you that it's really a privilege to speak to an audience of patients. I mean, after all, you are the reason that we come to work every day. So I know we have a great program prepared for you, and I look forward to learning with all of you. So my job today is to talk to you about the surgical management of neuroendocrine tumors and potentially how to choose your surgeon and kind of navigate what may need to happen should you need a surgical resection. So the incidence of neuroendocrine tumors is consistently increasing, and this is likely due to better diagnostic modalities and more familiarity with NETs in general. You can see here from a paper published in 2017 that the annual age-adjusted incidence of neuroendocrine tumors was about 1 per 100,000 persons in 1973 and increased to about 7 per 100,000 persons in 2012. So neuroendocrine tumors can arise anywhere in the body. The origin of the cells from which they arise is not completely well understood, but we do know they can come from anywhere. They're called neuroendocrine tumors predominantly because they can be stimulated by nerves, and endocrine because they can secrete hormones. Most commonly, we see NETs that have originated in the small intestine, secondarily the lungs, and the pancreas, but it doesn't mean that they're confined to these sites only. What's interesting is that 1 in 2 US patients were diagnosed with other conditions when they in fact had neuroendocrine tumors. And many of you in the audience may have experienced this personally. You may have been told that you have irritable bowel disease, gastritis, or anxiety, when in fact you just had a neuroendocrine tumor. So I think this the increased diagnostic ability to find these tumors and the increased knowledge that these tumors exist is potentially one of the reasons that we're seeing kind of the staggering increase, and not necessarily that the incidence is in fact increasing. So after your diagnosis, what should you expect? Well, first and foremost, I think it's of paramount importance that you connect with a neuroendocrine tumor specialist. You should discuss your options in terms of treatment and why they may be right or wrong for you. There might be recommendations of medical treatments or surgical treatments or other therapies. When you find your physician, we have specific responsibilities, and our job is really to provide you with easily understandable information regarding your diagnosis, to provide you with a list of options, and to provide you with the pros and cons of each option and how it may relate specifically to you. You as the patient also have some responsibilities. Your job is really to inform us of your symptoms, your lifestyle, your goals of treatment, and your past experiences. So you can imagine, I'm a surgeon, and if you've had surgery and it's gone terribly wrong and you're terrified of surgery and you come in and see me and I'm recommending surgery as the first step, that might not necessarily be what you want to hear. So it's important for me to know what your goals of treatment are and what your past experiences may have been, so that we can facilitate essentially the easiest transition into the next step moving forward. So how should you choose your surgeon? Again, try to find a specialist. You can ask your surgeon if they participate in a tumor board or if they work with other NET specialists routinely. You should also trust your provider's knowledge and feel empowered to add your own perspective. So you have to feel comfortable, again, with your treatment team and believe that they are doing the best thing for you. And if something doesn't feel right, or even if it does feel right, don't be afraid to seek out another opinion. That's a perfectly reasonable approach. So what if you need surgery, or how do you know if you need surgery? Well, it depends on a number of things. Symptoms. Is your tumor functional or non-functional? Do you have symptoms like obstruction or bleeding? All of these things play a factor when we're deciding whether surgery is right for you. Additionally, we have to consider other factors like your overall health. Are you a good surgical candidate? Some patients may in fact have something known as carcinoid heart disease that sometimes requires surgery up front before we can do anything to actually treat the underlying cancer. So functional and non-functional tumors, just briefly. One is functional tumors that present with a carcinoid syndrome, and that means that your tumor produces hormones like serotonin that can cause flushing, diarrhea, bronchospasm, and ultimately heart disease. And then there's functional tumors in the pancreas, known as functional pancreatic neuroendocrine tumors, and this is about 40% of pancreatic neuroendocrine tumors. And then there's non-functional tumors, and non-functional is what I am before I've had my first cup of coffee, but the definition is that you're asymptomatic, or your symptoms are not necessarily from hormone excess. So that's kind of one way to think of hormone-producing and non-hormone-producing tumors. So if we think about pancreatic neuroendocrine tumors, there's a few reasons that you may want to take them out. If the tumor is functional, meaning it's making a hormone which may be causing a problem, it should come out. If you have a non-functional pancreatic neuroendocrine tumor, and it's 2 centimeters or larger, actually, it should be removed. There's good data to suggest that these tumors may progress fairly rapidly, and they could spread to lymph nodes. If tumors are less than 1 centimeter, they can stay. Typically, the rate of growth is slow. If we choose not to resect the tumor because of size and it's less than 1 centimeter, then typically we will continue to follow you with routine imaging to make sure that there's no significant growth. There is data to suggest that as you kind of get closer to the 2 centimeter mark, we want to consider removal again because of the risk of potential nodal disease. But additionally, this is a group of patients we can easily follow. Additionally, if you have an isolated non-metastatic high-grade tumor, so if you have a neuroendocrine carcinoma or a grade 3 carcinoma of the pancreas, if it has not spread, then independent of size, that's a tumor that we would like to remove. So if you look at the image on screen left, you can see that the pancreas is divided essentially into the head and the tail. And this is divided based on the vessels right there in the middle, the purple and the red, the SMA and the SMV. And tumors that are to the left of that are in the head of the pancreas. And to resect those, if they're fairly central and potentially involving the duct or surrounding the duct, you need to have what's called a Whipple procedure, which is demonstrated on screen right. And that essentially means that we need to resect that portion of the pancreas with the associated small intestine and a portion of the bile duct and reconstruct all of that so that you have appropriate flow of enzymes, bile, and food from the stomach. If it's to the right of that line where it says Whipple, then you can essentially undergo a distal pancreatectomy, which doesn't require the resection of any adjacent bowel or portions of the biliary tract. There's also the option for an enucleation. So that darker beige, greenish dot that I have at the tip of the pancreas there, if you can entirely remove that without injuring the underlying duct or any vessels, then you can essentially just remove that tumor without removing any adjacent portion of the pancreas. The small bowel is the most common site of neuroendocrine tumors in the GI tract. There's an incidence of about 10 to 12 per million patients. About 50% of these tumors are multicentric or multifocal, and they're typically well differentiated, meaning they're slow growing or indolent, but they can present late. And so sometimes we see patients who have advanced disease and maybe have been found to have a small bowel tumor because they either have a very large mass in their mesentery, that's where the lymph nodes are, or metastases to the liver. It's not uncommon. So what are the benefits of primary small bowel tumor neuroendocrine resection? Well, it could be curative if it's your only site of disease. It may prevent future metastases, local or distant metastases. It can prevent or alleviate bleeding and obstruction. It may reduce your hormone levels, and also it may improve survival. So there is some data from retrospective analyses that shows that there's an improvement in survival in patients who had metastatic disease, who had their primary tumor removed. This is data that is taken into consideration and may provide benefit to a certain subset of patients. But additional future studies need to be done in order to validate this entirely. On the next slide that you're going to see, there are some images from the operating room. So for those of you who are sensitive, I just wanted to let you know. So what is the surgical approach when dealing with small bowel neuroendocrine tumors? Well, it really depends on the extent of disease and the tumor location. Frequently, we can do these laparoscopically or robotically. But what you have to keep in mind is that the standard of care is to palpate the bowel manually. So the image at the top of the screen, you can essentially see that we can make a very small incision and extract a proportion of the bowel through that incision in order to be able to feel it. The reason being, like I told you, that about 50% of these tumors can be multicentric or multifocal. And sometimes the additional foci of disease can be as small really as a sesame seed. And when we're using laparoscopic or robotic techniques, we don't have the same tactile feedback that we may by essentially palpating the small bowel. And so usually there's a small extraction site that could be made, and it's typically a laparoscopic assisted or a robotic assisted surgery. Sometimes you have to make a larger incision because there's significant associated nodal disease within the mesentery. And in order to resect all of that, you're having to take out a pretty high proportion of intestine, and you also want to do the manual palpation in that setting. What about removal of your gallbladder? Well, if someone is going in there for something, it makes sense to do the cholecystectomy, and the reason behind it is typically patients who go on somatostatin analog therapy may ultimately develop complications from biliary colic and gallstones and require a cholecystectomy. So in the setting of you requiring an operation, it's not unreasonable to consider cholecystectomy at the time of your surgery. So here you essentially can see a representation of what we see when we're in the operating room. So in the image to your left, there's the colon on the far left, and then there's the small intestine with its associated mesentery to the right. And you can see all those vascular arcades. Between those vessels, those red things, that's where the lymph nodes live. And these small bowel neuroendocrine tumors, if you look at the image on them, right, they develop within the small bowel, and then the tumor can flow into the lymph nodes that are adjacent to that piece of small bowel and become involved with malignancy. Once that segment of intestine is cut out, then the two other ends are put back together, and essentially you're on your way to recovery. So what if I have metastatic disease? Well, it's about 50% of patients present with metastatic disease. This is data from a big cancer registry, and about looking at 29,000 patients who had neuroendocrine tumor, about 50% of them presented with metastatic disease. So if we're looking at liver metastases specifically, how do we manage them? Well, there's a variety of therapies, including systemic and liver-directed therapies, which you'll hear about, but I just want to highlight liver metastases kind of come in a variety of different forms. So if you look at the three images to the right, you can see someone who has, metastases on both sides of the liver, but not so many. Then there's someone who has a fairly more significant metastases that are smaller throughout the liver. And then the last image that you could see on the bottom, this person has fairly extensive metastatic disease in the liver. And so the treatment options for these three patients may be very different, or they may be similar, just in a different stepwise fashion. So what are the next steps when determining what to do with neuroendocrine tumor mets? So is your disease localized to one organ? So for example, did you come in with a small bowel neuroendocrine tumor and you have no additional disease, then you would essentially fit into the algorithm on the far left. You would have a complete surgical resection, ideally, and then you would have routine follow-up to evaluate for disease or recurrence. If you had metastatic disease with heavy tumor burden in the liver, then we have to consider, are you a surgical candidate? Should you receive liver-directed therapy? Is PRT an option, or should you receive systemic therapy? And there's numerous factors to consider in order to make these decisions. And then on screen right, what if you have heavy tumor burden that's widespread, including the liver, but maybe also metastases to other locations? Again, in that setting, we kind of have to take into consideration the whole picture, and you may be amenable to having systemic therapy, PRT, liver-directed therapy, and surgery. So when do we want to consider surgery for neuroendocrine liver metastases? Basically, when we can resect all of the disease, or when we can resect at least 70% of the disease in the liver. There's good data to suggest that with 70% reduction in patients with grade 1 and 2 neuroendocrine tumors, there is benefits in progression, free survival, and certainly overall survival and symptom control. The patient should obviously be a healthy surgical candidate with a healthy liver. Sometimes previous liver-directed therapies may preclude you from having specific types of surgical intervention. So we need to consider your overall liver health. And sometimes we consider surgery if you have progression of a specific lesion. So let's say you had 6 or 7 lesions in the liver, and 5 of them are behaving perfectly well, but one of them is misbehaving and continues to grow or change. If it's amenable to resection, then we may favor going in and just removing that one to get more pathologic information. And then also you can consider treating the additional disease while you're in there. So anatomy and approach. As a liver surgeon, essentially when I look at the liver, what I think is of the image to your left, and if you look here, you can see that the liver is highly vascular, and it's got multiple branches of arteries and veins coming in and out. And it's got multiple branches of bile ducts that are essentially draining those segments of the liver and returning blood to the intestine. You can imagine if you look at kind of the panel on the right, if you look at panel A, if you had that lesion sitting high up there in segment 2, right, that's pretty peripheral, it's on the edge, probably would be pretty easy to cut out. So there's 2 options that you have there. You would do a left lateral sectionectomy, which is an A1, or you could do a wedge resection, meaning you just remove that tumor with a little bit of healthy surrounding liver. We favor what's known as the parenchymal sparing or liver sparing approach, meaning leave as much healthy liver behind as you can and just take what you need. So again, MIS approach, that means minimally invasive. This could be done open. Depends on the extent of disease. This could be done robotically or laparoscopically. So here's a robotic case that we did just the other day. The patient always asks, where are you sitting? And I'm in the corner with the pink arrow. And you can see that, we're removing a tumor in the liver robotically. What about the ablation technique I mentioned? Here we are doing a combination of laparoscopic resection followed by ablation. So in order to do the ablation, we basically use an ultrasound probe to see deep within the liver, because usually these tumors are central. Otherwise, we would just be usually removing them, cutting them out. Using the ultrasound probe, you can see where the liver tumor is, and then you're able to put your probe essentially directly into the liver under visualization. And then the machine, you can see kind of that's right in front of me in the operating room picture. That one allows us to essentially cook the tumor for a specific period of time at a specific wattage, and we're able to watch with the ultrasound while that's being done. So why surgery for neuroendocrine liver metastases? Well, certainly it could provide a potential for cure if that's the only metastatic disease that you may have. We do believe that there's a survival advantage over no surgery at all. It can help to reset the clock in appropriately selected patients. There is the surgical debulking concept that shows that if you can reduce 70% of the tumor burden, there is a benefit to patients with progression-free intervals, and also especially in patients who are symptomatic and symptom control. And honestly, we have decreased complications with newer techniques. So with the tissue sparing or parenchymal sparing surgery and the use of ablation, we're not having to do 70% removal of the entire liver just to take out one small lesion that's sitting centrally in a bad location. What about life after surgery? Truly, the recovery depends on the type of surgery that you've had, what part of the body was your operation on, which organs were removed, and how extensive was your disease. Also, one thing that's of paramount importance is that recovery depends on your overall health. And what should you expect? Again, you're gonna have some pain. It varies based on the operation. We will manage your pain with appropriate medications. That's our goal. So if your pain's not being managed, you need to let your medical team know so that we can make it better and make sure that there's no issues that we're not aware of. You will typically be expected to walk the day of or after surgery. You will be started on a diet. I say eventually because if you had lung surgery, you're probably going to get a diet the same day. But if I just took out, a huge proportion of your intestine, pancreas, or did an extensive debulking of your liver with resection of the small bowel, I'm probably going to wait a few days before I give you anything, just to make sure that everything's awake and ready to tolerate it. How long you stay in the hospital is really based on all of the above, but your surgeon should be able to give you an estimate based on their previous experience. And your surgeon should also have a discussion with you about potential complications should they arise. And then after that, we continue with routine follow-ups with appropriate members of the treatment team in order to monitor your progress, monitor your neuroendocrine tumor, discuss the need for options or for additional treatments. And between visits, you should keep a log of questions that you may have. Keep a log of symptoms that you might be experiencing, especially, if they're important, make sure that you call us. If something doesn't feel right, please don't wait before your next visit to give us a call. And with that, I'd really like to thank LACNETS for the opportunity to speak to all of you. I hope that this provided some educational information for you, and please feel free to reach out should you have any questions. Thank you.